as a psychiatrist, I can say we typically think what we do is special, and it is very special, but it doesn't defy like logic, right? And I think we have to all get on board with the idea that what we're doing can also be measured. It's not so special that there's no way to quantify it or measure it.
Hi, welcome to Season 2 of Neural Compass. I am your host, Marc Jacobstein. I'm really excited today. I have not one, but two guests. We're getting two for the price of one here with doctors Amit Parikh and Dr. Arpan Parikh, who are brothers who have both ended up in the same profession. We're going to talk about that a little bit. Both psychiatrists and both working in a field that we're really passionate about here at Jiminy Health. So just do some very quick introductions here. Dr. Arpan Parikh is a double board certified psychiatrist who currently serves as a chief medical officer at Soul Mental Health, spearheading the growth and clinical strategy of a multi-site outpatient mental health group in a very fast-growing startup. He earned his doctorate from The Ohio State University College of Medicine, completing residency in adult psychiatry at Mount Sinai. We're going to talk a lot about his work across a lot of different patient populations today. In addition, I'm here today with Dr. Amit Parikh, who is the Chief Medical Officer at Brave Health. We're going to talk a lot about his work there and in fully virtual care and what that's meant for his patient population. So thank you both for joining me here today. Let me start with the journey. Tell us a little bit about growing up and how you both ended up in the same field and what drew you to psychiatry.
Yeah, sure. I can kick it off and I'll hand it over to Amit. So this has certainly become the family business. Our father is a psychiatrist. So we both grew up around it. I certainly grew up around it, spending time in the office, seeing how fulfilled he was with the work he did. And at least for me, that set into motion the early intuition that I wanted to become a doctor. I went into medical school with an open mind and actually was pretty close to becoming a pediatrician. And then I had my psychiatry rotation, which was at a really high acuity state hospital in Columbus, Ohio. And I think that is what sealed the deal. I just really fell in love with the types of conversations I had the luxury to have with my patients, the time I could spend with them, getting to know them on a really, really intimate level and understanding the deepest thoughts and emotions and feelings and being in this really great position of being able to help them with something that not many folks are willing to help them with, right? This was back in the early 2010s when the stigmas towards treating mental health conditions were much more robust than they are today. And the barriers were much larger. So that set me on this path and I haven't looked back since. And it turns out that was a really, really good decision, both from a fulfillment perspective, but also from a timing perspective, because, here we are 10 or 15 years later, and it turns out this has become a really important world, an important specialty in healthcare. And there's more understanding of the intimate relation between mental health and physical health and how important this is to the entire healthcare system. So it's been a really fun journey so far.
Thanks so much for that, Arpan. It's really interesting. I hadn't thought this one through, but if you think about it, there's a lot of medical specialties where the physicians don't get to know their patients very well. They see them sporadically in bursty moments, perhaps only once, depending on the specialty. And doesn't mean that it can't be fulfilling in its own way. But of course, I think very different than where you're working with a patient over the course of months or even years. Really be interesting to map that out in terms of different specialties. And how about for you, Amit?
Yeah, similar, of course, growing up, saw the fulfillment. My dad got out of practicing as a psychiatrist and just as a physician in general. And pretty early on knew I wanted to be a physician. And so I was pretty certain I was going to be an orthopedic surgeon, actually. And that's what I spent a lot of my early med school years doing, research-wise, learning about, spending time doing. But then kind of for those of you who know, in your third year of medical school is when you spend time actually on the wards then, in front of patients, working with teams. Spent about 6 or 8 weeks doing just orthopedic surgery. And what I realized is that I would want to spend more time in clinic than I would, and like talking with patients and getting to know them, than I would in the operating room. And if you know surgeons, their favorite place is the operating room, and there's no surgeon whose favorite place is the clinic. Because that's what they go into the field to do, is to operate. And so I quickly realized that, okay, maybe there's something else about this that I like. And reflecting, I realized that I really enjoyed my rotation in psychiatry. It was very easy to be like, well, that was definitely the most enjoyable rotation I had. And now looking back, I think, the way I think about this is that I enjoyed those fields for a similar reason. And it's that you can read as much as you want about how to do a surgery or about how to interview a patient, for example, in psychiatry. But until you do it and practice and do the reps, you can't actually get good at it. The same way with the surgery, you could technically read how to do it, but until you're actually doing it over and over and over, you don't get good at it. And there's something about building a skill that I can get really good at outside of just like reading about it from a factual standpoint is intriguing to me. And so I think like it was a very easy fit then for psychiatry. Early on, my method, I'd be like, no, I'm going to do orthopedic surgery. I'm not going to use psychiatry. Lo and behold, I ended up picking psychiatry. When I started training to become a psychiatrist, I was like, I could do anything in psychiatry. I don't think I'm going to become a child and adolescent psychiatrist. I was like, it's probably not for me. But here I am now also as a child and adolescent psychiatrist. And I think what that's all taught me is like always having an open mind is like what you think isn't always necessarily what's going to happen. And just like being willing to have like different experiences, kind of like Arpa mentioned, and leaving yourself open to where that like opportunity or excitement will come from.
What a fantastic journey, and I suppose representation of your own sort of neuroplasticity, which is probably something and grit that you want to teach to your patients as well. It's interesting I've never thought about this. You'd think I would have. My wife is a physician. That I don't know how much they do in medical school to walk you through sort of given your personality types and what you care about, which of I mean, there's a huge difference between being an orthopedic surgeon and being a child and adolescent psychiatrist. I think there's a couple of years of medical school training that overlap, but really it's a pretty different life. I'm curious whether the medical schools today are doing more work to help the students think about that, or whether it's just sort of like, go do your rotations and see what sticks.
I think it's getting better over the years of teaching folks to think about like what will gain you satisfaction in the long term. I think it's also tough as a medical student because you only do short periods of time in these specialties, and you tend to focus on higher acuity hospitalized patients for a lot of the time. And so your perception of each field is like this like very narrow window. And so I think it's like an innately hard thing to do. And then the last thing I will say is that how this ends up happening, or at least how I see it end up happening a lot, is you'll find yourself getting along with a certain group of individuals. And as you know, like different physicians have like different personality archetypes that are at this point like memes probably, but it's true to a certain extent, right? Like like-minded people tend to, find their like-minded peers. And I think that kind of happens through the process. I don't know if it was like that for you, Arpan, too.
100%. The second day of a rotation, if this is my people or not. And that's not very scientific. And I hope medical schools are being more intentional about this. We could do a whole podcast on undergraduate medical education. There's a lot of opportunity there, but it's a great point, Mark. Like, we should be training our future physicians to think about what they want out of their life and their career and making really important decisions that are aligned with those outcomes.
Maybe we'll do another podcast. There's a whole conversation to be had about the way the medical profession works and the strengths and weaknesses. And one of the things I'm always fascinated with is the depth of the status quo bias that exists in medicine, which is there for good reasons. I mean, status quo bias is a thing in all fields, but is particularly a thing in medicine, in part because first, do no harm, because these are real patients, so shouldn't be a cowboy and experiment with, but also because of the nature of personalities of people who can make it through 4 years of medical school and the nature of the training and all the rest of it. But so what that means vis-a-vis innovation in the field, I've always, as somebody who's not an MD, not a PhD, but has spent a lot of time in health tech, always interested in the differences in the personalities and the training and the way that then impacts the way, say, health interacts with, say, health tech. So maybe we'll use that as a segue, actually, to dive into some of the conversations I really wanted to touch on today, sort of the intersection of psychiatry and psychology, and some of the things that are happening in AI, and the care that you guys are providing, at your organization. So one of the things I know you've both written about, and if folks haven't read it, there's a wonderful Substack, two docs in a stack, that the brothers have been putting together here for years. And one of the things you guys have written about is MBC, or measurement-based care, which is something that I think in the last 3-4 years has become a very hot topic in the world of mental and behavioral health. And so first of all, may I ask one of you to explain what is MBC? And then my follow-on question here is like, talk to me about like the practical realities of implementing MBC sort of within your organizations, and which measurements actually change care, and sort of not the sort of academic paper version of this, but like the practical realities of trying to implement MBC. So I don't know who wants to take this one first.
Amit is a world-class expert on measurement-based care. So why don't you do the explanation of what it is, and then I can take first stab at what it means practically.
Yeah, that works for me. And so, yeah, measurement-based care is a hot buzzword these days. Like, it's a new thing, but the reality is measurement-based care is the foundation of every single field of healthcare, right? It's the simple idea of trying to have objective measurement tools to track something, anything, right? Whether in physical health, right? When you go to your primary care doc, you're getting your blood pressure, your height, maybe you're getting your hemoglobin A1C for diabetes risk, your cholesterol checked, right? You're getting numbers checked that are somewhat more objective than just asking questions to the patient about how are you feeling, right? And then you combine what you see in front of you and what you hear from the patient with some of those objective measures to come up with a plan to help the patient, right? And so in behavioral health, if you go back 20 years, 30 years, no one was doing measurement-based care in practice, even though, to your point, on the academic literature side, it's always been the case, right? We've always, in research, you always have to use tools to track symptoms. But there's been a big push to say we should be using these same tools or similar tools in everyday practice to help bring an objective lens to the visit. Now, don't get me wrong. It's not to say that the use of these tools takes place of the subjective portion of the visit or is the sole truth. It's just an extra data point, and more data is always better, right? Because sometimes the tool is going to tell you one thing, what you're seeing is different. And that's really important information too, right? And so it's just a way for us to capture more data, slightly more objective way, so that we can really make sure that we're getting to the outcomes and we're getting to the objectives and goals that we want. And I mean, there's so many benefits across the system that it's pretty wild to think about. But yeah, at its core, that's all it is. It's PHQ-9s, GAD-7s, et cetera, et cetera. Not that those are my favorite, but
right. And for those who don't know, GAD-7 is a standardized test to essentially assess anxiety levels. PHQ-9 similarly for depression. There are some more modern versions of these. I guess Vanderbilt, they're PSC-17s, et cetera. I don't know if you have particular thoughts or feelings about the which test, but my sense has always been that like it's so much better to have some sort of objective measurement. Something as opposed to nothing is so much more important than sort of the nuances of which of the particular scales you're choosing. I don't know if that's your perspective.
Definitely agree. Definitely. Right. And I think people get scared because they think that the goal is to make it the sole data point, but that's no one's goal. And I think that's what we have to keep reinforcing with clinicians and just the broader ecosystem is that, as you said, it's just more data.
So maybe this will tie in then to Arpan's answer in regards to like the application of MBC in sort of practical use cases. Seems fairly obvious. You would never treat somebody's diabetes without understanding what's happening with their insulin levels and a glucometer, et cetera. And you'd never have an annual well visit without checking the cholesterol of somebody who's 55 years old. Why has this had to be sort of a push in mental and behavioral health? And talk to me about what it's actually meant for you to implement within your practice, Arpan.
Yeah, it's a great question. So I think as a psychiatrist or as a behavioral health clinician myself, I can say this. Typically, psychiatrists, behavioral health clinicians tend to be on the lagging edge of innovation and change. And this is, I think, one great example of our specialty in our field being behind the times, right? Like Amit said, most other specialties today have measurement-based care at the core of what they do, whether it's cardiology or endocrinology or rheumatology. Name your specialty, right? There are hard and fast metrics that are used as part of understanding a patient's progression in treatment and their care. We are really, really late to the game, and I do believe it is likely driven by our stubbornness as a field, right, to adopt this. I think as a psychiatrist, I can say we typically think what we do is special, and it is very special, but it doesn't defy like logic, right? I think we have to all get on board with the idea that what we're doing can also be measured. It's not so special that there's no way to quantify it or measure it, right? So I think that's a really important internalization we have to make as a field, and we're starting to, which is really, really nice. I do think it's fair to say there has probably been an over rotation in this direction over the last 4 or 5 years. So we were really slow in the last 20 years. And then, a little bit before the pandemic. And then as the pandemic hit, this became of high interest to a lot of interested parties, including the government, including payers and employers. And I think now in 2025, we've actually too far over rotated in the direction of specific components of measurement miscarriage, specifically the standardized clinical scales. And I think today there's actually too much focus on things like the PHQ-9 and the GAD-7.
I can see that happening in part. I mean, payers drive a lot of behavior, of course, in healthcare. I've had this conversation myself with payers where one of the frustrations they will express about mental and behavioral health, they all appreciate how important it is. They all understand that untreated mental health challenges are a disaster for the patient and for them, frankly, because it leads to lots of downstream costs and complications. But they're also frustrated when they don't have any way of measuring, without measurement-based care, they don't have any way of measuring the efficacy of the various therapies that a patient is getting and understanding who's doing good work, who's not, what types of therapy are useful, which are less so, and whether somebody's even practicing sort of evidence-based medicine or not, and as such, so I think that's been sort of part of that strong push.
Totally.
One of the things I'm curious about, because there's sort of the administration. One way to do this is 7 to 9 multiple choice questions, which is sort of what a PHQ-9 or GAD-7 feels like. A different way to measure how someone is doing in a, I think, reasonably objective way is to have an AI that speaks to your patient maybe every day. And one of the interesting things, we'll get into this a little bit more, you talk about sort of continuity of care, et cetera, that patients in many mental health settings, it depends on how acute the situation is, et cetera, but maybe they only talk to their therapist once a week, once every couple weeks. And what they end up getting, even if they're administering a PHQ-9 or GAD-7, et cetera, is a time slice. And of course, there's 168 hours in a week, and people go up and down. And anyways, I'm curious about your thoughts about using tools, AI or not, to try to ascertain how somebody is doing, and then using that to inform the conversation with the therapist that they're going to have whenever they have it.
Yeah, I think there's kind of 2 pieces there, right? The first piece is we should always think about, with measurement-based care, 2 questions, right? One is, how are we gathering the information? And second is, what questions are we asking? So I think the concept of using next generation tools like artificial intelligence tools, right, to ask these questions or gather the data in an interesting way, and then also gather different data points is really, really interesting. And I think the over-rotation that's happened with measurement-based care in the last 5 years in mental health is not necessarily on measurement-based care itself, but it's on actually the PHQ-9 and the GAD-7, right? So to the extent we can use tools to tease out similar insights without relying on patient-reported questionnaires, I think that's super, super interesting. There's some other interesting nuggets in there, right? Which is ultimately at the end of the day, what payers and employers are controlling for is cost, right? And what they want to be cognizant of is folks being in therapy forever, which there are benefits to. And I personally believe seeing a therapist weekly is like going to the gym weekly. But there's a fair question of, should my employer, right, be paying for that vis-a-vis my employer sponsored health insurance? They don't pay for my Equinox membership, right? So to the extent we can use these types of tools to gather the insights of when a patient or an employee has reached their goals in treatment. I think that's extremely valuable.
Hmm.
I'm not sure the patient in the Get7 and asking them in the questionnaire format that's filled out by the patient is the right way. So, long way of saying, I think using next generation tools to get this information, whether it's asking the questions in a more natural language format, doing it by audio versus by the patient filling out a form, or it's by actually imputing that data by understanding the tone and color and context and cadence of a patient's voice. I
Yeah.
think that's incredibly interesting and actually helps move us forward.
Yeah. There's a lot happening in sort of AI driven biomarkers from in tone and inflection of voice. You can look at somebody's face. I mean, it's actually not surprising as human beings. You can see it. You can tell when somebody's not doing well, right? I mean, if you're an empathic person, you will often sort of ask somebody how they're doing because it looks like they're not doing so good. Anyways, I think your point about sort of when to tie off care also, at least from, say, a payer's perspective, like you can choose to continue on this journey because it is interesting and helpful to you, like going to Equinox. But that is different than you're in a situation where you really need help, you're sick, et cetera, and I, as your insurance company, am sort of obligated to cover that. My own personal care journey on that. Like, I think some of the first therapists I worked with for a very long time, there was sort of never a goal or an end date. And that has changed a lot in the last 5, 6 years. I think people are much more cognizant of that. So speaking of sort of the complexity of care and end dates, et cetera, one of the things that's interesting, I think there's a lot of awareness in mental health. There's a lot of people with, say, anxiety and depression who struggle, but who are, I'm going to call it like garden variety anxiety, for example, tens of millions of people. And it is a very, very serious and real thing. I personally struggled with it for decades, and it was terrible. But it is different than serious mental illness. And a lot of the toughest situations in mental and behavioral health are with chronic and complex, serious mental illness that require an integrated continuum of care and more than just like go see your therapist once every 2 weeks. So, talk to me a little bit about how you think about that and what tools are useful for you in the continuum of care and sort of because I think for many listeners, like behavioral health, mental health, they think about what psychiatrists do. It's like you write scripts for meds, maybe an SSRI, and every week or two there's a therapy session. And like that might be true. And for some patients, maybe that's adequate. But for a lot of patients, it's not. And there's a lot more to providing care these days. Let's start with you, Meet. When you want to sort of talk through how you think about the continuum of care, and especially dealing with complex and chronic situations.
Yeah, that's at Brave. That's kind of a large population of patients we see as a company that accepts Medicaid in all the states that we're in. Those are these patients who have SMI a lot of times end up on either Medicaid or then Medicare because of the impacts and consequences of their illness sometimes make it such that that's the way that they're going to be able to get the care they need. And so one is just access, right? The access system for patients, especially when they're leaving places like inpatient psychiatric units, is pretty terrible. A not uncommon thing that a patient will be told is there's a clinic down the street. We can't make an appointment, but they're open from 8 to 5. Just show up and wait for a visit. And that's what the patient gets when they leave the hospital. And that wouldn't cut it in any other field, right? Like you couldn't say that, oh yeah, just show up at the cardiologist's office after you were in the cardiac intensive care unit, and then they'll just try to get you in when it works.
Good luck with that. I hope it goes well.
Yeah, I hope, right? Like it's like a crazy thing to happen. So one is just like actually making it so that these patients can attend their visits, thinking through the barriers, right? Like if you have someone who doesn't have stable housing, who doesn't have access to transportation, but then you tell them to go to a clinic, which is 30-minute drive from their location, like good luck, right? It's just not going to work. And I think that's the reality for a lot of these patients is it's how do you bring the care to them, whether that's wraparound services in their community, social workers to actually get them and take them to the visit using virtual care, which is what we do at Brave, right? We use virtual care. So we're meeting them where they're at rather than expecting them to come to us. And I think there used to be this sense of like, how can you treat patients who are complex virtually? But the reality is like for a lot of patients we see, there is no in-person option, or the in-person option hasn't worked forever for them. And so like it's about, in my mind, for this population is just making care easy, making it actually feasible to attend and do, and then just delivering good care. And great, like if you get them to the visit and deliver good care, you can see amazing outcomes for these patients without having to like rethink through some brand new paradigm of care. Quite frankly, like the treatments we have work. It's just about like getting patients to stay consistent with them.
Some of the challenges you point out that don't happen in cardiology, right? Why has that historically been an issue for behavioral health and versus some other specialties where I feel like the integration of the sort of complex pieces of the healthcare system work a little bit better? To be fair, things fall apart in other parts of the healthcare ecosystem too, and coordination from one center to another is not always that easy. But I think it is a fair assessment that it's been more siloed in behavioral health.
I think it's a number of different reasons, but we'll let Arpan's take on this too. But I think obviously some of it is driven by the system and the way things are paid for, right? Like the reality of the situation is the reimbursement rates that organizations are able to get for providing behavioral health care aren't in line with typical labor costs today, and don't value what's actually happening. And so it's much harder to build cool systems companies to do this in a way that makes sense, which is why a lot of this care gets put onto, grant funded, federally funded, like other types of external funding to actually make the care possible. Right? Like most systems, if you talk to most hospital systems, tell you that they'll lose money on their behavioral health care they deliver because it's just impossible to actually have any margin there. Which is, I know, not clinicians' favorite thing to talk about, but it's their reality, right? Like, and I think that has driven a lot of the ecosystem and the way it is today.
It sounds like a lot of your population is Medicaid population. Have you found that this is you're able to make this work though? I mean, and it sounds like underpinning a lot of this is the virtual care, which probably not only allows you to bring care to patients where they can actually receive it, but keep your own costs down as well. It's a lot cheaper than running a large hospital, for example.
Yeah, yeah, absolutely that. And then it's with us proving our value to the system to then, partake in value-based deals or, with our payer partners when we're able to prove out the value we're bringing, which happens very quickly, right? And we're able to prove a total cost of care reduction, not just behavioral health, which, has been the historical silo, but like saying, no, 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 like when you have all these complex chronic patients who have, end stage renal disease, end stage heart disease, when you actually get them into the right behavioral health care, their total cost drastically decreases, which I think has been proven over and over again now in the literature.
It's so interesting. I think it has been proven over and over again. And you talk to payers, and I think that they will acknowledge that. And yet, to your point, historically, like that hasn't been aligned with how they think about it. And part of this is probably the siloing of budgets. There's somebody whose budget is the mental and behavioral health costs, and there's somebody else whose budget is various other chronic diseases that are intertwined with somebody's mental health. And I think of serious mental illness and is along with say anxiety and depression as like the ultimate comorbidities. But anyways, that's a longer conversation about the pair. I'm curious, and maybe throw this one over to Arpan. I mean, part of what we're doing at Jiminy is trying to help with this sort of continuity of care. So building software and AI tools that help with like onboarding and engagement and adherence and retention and all the things that are sort of around the successful delivery of care, which is different than like we just make a therapist better in the session, right? But I'm curious, if you're seeing tools that are helping. Maybe you're building your own inside of Soul. And so, how you think about this continuity of care?
Yeah, it's a really good question. I mean, it's an exciting time right now with so much innovation and focus on evolving or revolutionizing both the patient journey and the clinician experience, right? And the pace at which we're able to do that, given artificial intelligence as a space, is just leaps and bounds beyond what it was 5 or 10 years ago. So I think generally speaking, that's really, really exciting. I think on the specific point of kind of the coordination of care and transitions of care, like I think there's going to be a lot of different ways to attack this. It is at its core a structural problem, to Amit's point, right? Given the way economics are arranged, given structural stigmas and siloing that still exist and will probably never completely go away, even though we're a long way from where we were 5 or 10 years ago. So I think given those structural pieces that are probably not going to change anytime soon, it's even more important that we begin utilizing and leveraging new types of technology to help us get around them, right? So I think, for example, the way Jiminy engages with patients, 24 hours a day, 7 days a week, 365 days a year, in between sessions, and with the clinician during session is one example of how you get around some of that structural, just like the system is kind of tilted against patients and clinicians, right? Who are either on a mental health care journey or trying to deliver mental health care. Similarly, there are other ways to get at this issue to help us kind of sidestep the things that are in place and make these coordination of care journeys super, super challenging for patients.
Yeah, that absolutely makes sense. So, switching gears here a little bit, one of the things I always think about, like, because I help build startups, is like, what's the one thing, right? Like, what's the, like, if we got to get one thing right now. So I'm curious if you had like, what's one like underrated lever for improving quality at scale that you guys think about vis-a-vis your organizations?
It's a good question. This is going to seem like a really odd one, but I promise it makes sense.
I like odd is good.
Yeah.
Odd's interesting.
And I think it's an area where technology can actually have a lot of leverage, right? So in the work we do as psychiatrists and our teams do as therapists, one component of that work that's critically important for quality is arriving at a differential diagnosis, right? So that's the job of that initial appointment or the first couple of appointments is we're synthesizing a lot of data points, most of which are subjective and based on the patient's report, some of which are objective and based on our observation of the patient during the session, right? To arrive at what do we think is the most likely underlying condition that's driving this? Because that is then one-to-one linked with what the treatment should be. I think an area that's underinvested in right now that's really, really interesting to me from a quality perspective is to the extent we can integrate more sources of data into that initial assessment, the better the initial assessment gets. And then the more likely the treatment we choose is actually going to address the issue at hand.
And by sources of data, you mean sort of moving beyond just like the conversations you can have with them as a therapist, but data from elsewhere in the world. I mean, would that include sleep data, biometric data? Is that like conversations with peers and parents? How do you what sort of other data?
All of the above, right?
Okay.
So I think the couple that are the most interesting to me is definitely device data, right? Today, almost everyone has a smartphone. A lot of folks wear smart devices like Oura rings or Apple Watches or Whoops. Many people have smart devices in their home, like in 8 Sleep. So those are incredible sources of data that actually would be so interesting and so useful for a therapist or psychiatrist doing an initial evaluation. So that's one. And the second one is actually the one you mentioned, and I actually had a conversation with one of my psychiatric clinicians yesterday about this, is collateral sources of information, right? So a patient has one point of view of their world and what's going on. It's actually incredibly useful to get the point of view of other people who are in that patient's life, right? Their spouse, their kid, their parent. They've known the patient for 30, 40, 50 years. I've known the patient for 35 minutes, right?
It's just the equivalent of in the corporate world, the 360 review.
Correct. Yeah. But that's a really manual process today, right? Like telling me, okay, now go chase the patient's spouse and get the patient on board with me talking to them, and then get a release of information in place, find time for a conversation, have the conversation, then document it. That's a lot of extra administrative work to add. So I think this is a really interesting place where technology could actually help us speed up and also improve the quality. For example, collateral information gathering from loved ones or important people in the lives of our patients.
Or even social. So this is interesting. I mean, I've had this conversation with Lyle Unger, who's at Penn, and for that matter, Johannes Eichstadt, who's at Stanford, but also helps us with Jiminy. Like, there's all kinds of signal about how people are doing in their electronic communications and their social media, for example. I mean, depending on the age of them, whether they participate, but most people do. Now, of course, they would have to choose to share that with their therapist, and that would be their choice. But you could probably tell an awful lot about what's going on with somebody from their Instagram posts or their behavior. I just went down a 4-hour TikTok rabbit hole. Is probably not a good sign for somebody's behavioral health, mental health, and well-being. Well, so speaking of TikTok rabbit holes, Amit, I wanted to ask you sort of about like particular challenges of working with, kids and how you think about that with your practice.
Yeah. Kids are not little adults. And I think sometimes people think that, especially as they even, once they start to get into their teens, sometimes people are like, oh, they're just like, no, they're not. They're very different, right? And so first they're just appreciating and understanding that. And then also kids are not solo. They're part of a system, which is the other people in their life. And so you can't treat just the child. You have to treat the system, right? It's like impossible to fix what's going on unless you have everyone moving in the same direction. I think those are some of like that's the base and core of working with children is understanding and appreciating that. And then to Arpan's point, like this is where like collateral becomes so important, right? But it's also time consuming and hard. And you have, maybe you have two parents who are separated, and then you have another aunt who's also taking care of them 3 days out of the week because they're helping with childcare. And so you want all those data points, but it's really hard to actually compile them all together.
Well, and their peers may matter more than any. I, as the father of a 9-year-old, I am acutely aware that I only have about 3 or 4 more years where my wife and I are the most important voice in her head, and soon it will be her peers. And you're right about sort of the systems approach here.
And then the other thing I would say is that you have to be willing to be able to work with kids. You have to get on their level. You can't come in and be overly formal and be overly structured. That won't work, right? So for kids, they don't really sometimes understand even what they're feeling, why they're feeling it. They may be able to tell you they're feeling certain emotions. So it's up to you as a clinician to be a detective and have them tell you what's going on without them kind of even realizing it to a certain degree. And you're looking at behaviors and you're looking at the way they're answering questions a lot more because you can't ask a 10-year-old, are you, are you having thoughts of wanting to end your life? Because that might not even make sense to them. But they may be having a thought that's very similar to that, but you have to figure out the way to elicit that thought.
Fascinating. So I live in the middle of Silicon Valley, and so my life is I'm surrounded by all things AI all the time right now. And one of the things we spend a lot of time thinking about is ways that AI can improve things, whether it's improve productivity, improve ability to discover drugs, improve whatever. I'm curious if you guys could sort of wave a magic wand and have like one clinical task or administrative task you'd want AI to own completely, like in the next 12 months, within sort of your businesses, what would that be?
It's a good question. So when I answer this question, I think about it from two perspectives, right? It should be a task that, number one, doesn't require a clinician or a human to complete, right? It's not so complex that it requires that. And or number two, it's something that like is so out of the ordinary that like a human couldn't complete it, right? Something so complex. So like it's a brand new thing.
It either requires is like a super intelligence that or sort of banal and drudgery for a clinician.
Exactly. So I think for me, it actually goes back to the point we were making a few minutes ago, which is this idea of collateral gathering and hospital record gathering. And I haven't really seen anyone kind of bring the two together in a way that waves a magic wand and makes it seamless. But I think in addition to everything that's being built today, for which, and there's many solutions out there, we're using them, Brave is using them, Jiminy's building them, right? think about something net new that's not being solved, and like there isn't something, but I wish I could wave a magic wand. It's give me something that gives my clinicians and my clinic team a superpower in getting information from outside healthcare providers in an automated way. That doesn't require special skills. It requires persistence. It requires a little bit of ingenuity sometimes, right? It requires a little bit of understanding of how to have conversations and how the healthcare system works, which are all things that I believe an artificial intelligence tool can develop and learn.
Yeah, it's some sort of combination of like knowing what you need to go get,
Yes.
having API hooks to getting said information, and then AI to synthesize it into something that's actually usable. I actually think that the AI piece there is the easiest, and that the API hooks into the different data sources that you would need to gather, and sort of an understanding of what all those were is actually the more complex problem. Interesting. And for you, Amit?
I was going to say something very similar, which is it's the idea of and there are people who are starting to do this, I will say, which I think is great, but there's so much information out there. Like as medicine has gotten more complex, as we've gotten more treatments, more tools, the complexity of the care we're delivering today is like leaps and bounds over even what was there 30 years ago. Like 30 years ago, you could have like one book on your desk that covered like all of medicine basically and everything we did. And today, like one book won't even cover one subsect of cancer treatment for like one type of tumor, right? Because we're getting so precise. And what that means is the rate of knowledge is just expanding, expanding, expanding. As a clinician, though, you're now getting inundated with all these different notes from specialists from other places and all these data points, lab values. And it can be really hard to synthesize all of this
The
information.
human brain is still only 3 pounds.
Yeah.
And there's still only it's the same number of neuronal connections that we've ever had. You can't actually stuff any more in there.
And the problem is like we don't get, as a clinician, you don't get time to do it. Because like there's like you're seeing patients all day. When are you supposed to like pre-read on every patient all of this like pages and pages of stuff? And so like getting a concise summary of like, this is exactly what happened, but from all systems. Your patient went to the ED twice for chest pain, then they had a panic attack. They went to see their endocrinologist. This is what the endocrinologist said. They went to see PCP. They ordered this lab, and now they're here in front of you. Amazing, right? Now I know what happened between visits, and my visit is so much more impactful because of that.
I think what you're describing would be very powerful. It also feels very doable. I mean, again, this goes back to what I was saying earlier. The hardest part is having access to all the data. If you had the data, we can build models that understand medical information, understand specifically mental behavioral health information, understand the context of a patient, the notes that a psychiatrist or psychologist has included about them, and do a really good job of synthesizing. I mean, I have tools that are sort of analogous that I use in my business life that are incredibly useful. They haven't replaced the judgment work that I have to do, but they are a super intelligence for me in terms of information gathering, synthesis, and like it's like having a research assistant. But the information that I need is mostly readily available. I think that's the trickiest bit. Interesting. Well, thank you guys. This has been so interesting and useful. The last question I want to leave you both with, and I'm curious if there's anything you are reading, watching, listening to that people who are interested in such things would want to watch. This could be a podcast. This could be a book. This could be a show that you think is interesting for people interested in the subject.
Yeah, I have one suggestion. And this is geared more towards folks who want to really understand some of the pitfalls of the work that we do, which I think is important for folks who are building new technology. So one of my favorite books is written by a New York Post author called Brain on Fire. And it's a memoir of an experience that she had with a really rare disease called anti-NMDA receptor encephalitis, and how for months she was sort of gaslit by the medical system and misdiagnosed and written off as having psychotic illness, until she met one psychiatrist and one doctor who cared enough to actually ask the right questions and said, you actually have an organic brain disease that we need to treat with the appropriate medication, not subject you to a life of being on these medications that are not treating the underlying disease. So I think for me, it's a really important story because in our world, we deal with a lot of subjective. And I think in building next gen technology, it's important to keep that in mind. And we have to be really careful because for worse, the work we do still carries a stigma. And it's really important in our world to understand the root cause of what's causing a patient's suffering. It's not always as easy as chalking it up to depressive disorder, anxiety disorder, trauma, psychosis, etc.
Well, in that particular story, it gives me great sympathy, actually, not only for the author who suffered with this, but also, frankly, for the docs. Because I think about, like, in medical school, right? They say when you hear hoofbeats, think horses, not zebras. But every once in a while, it is a zebra.
Yeah.
And an NMDA receptor, as you say, is extremely rare, and longer conversation about probably related to some of the neuroplastogen stuff that people are doing these days, and sort of the opposite of the things that are helping to solve for some of these serious mental illnesses. But that's a great suggestion. I will put that on my nightstand. And Amit, for you?
Yeah, on a book, I would say a great one is The Body Keeps Score. It's kind of one of the first mainstream books that I think cracked open trauma for the public in a digestible way. But I think one of the really salient points to learn and why to read this book is it helps you bridge the gap and understand how psychological stress, emotion situations have actual lasting physical impacts on our body, and that there's a really strong connection between the mind and the body, which I think sometimes people don't appreciate or historically have been as part of the stigma. But it kind of talks you through in a very easy to understand way around like how it clearly does. And that like it does have real impacts on your body.
Yeah, that's fascinating. I would love to read that. And there's so much more evidence now about the gut-brain axis and what's happening with the immune system vis-a-vis your brain, not to mention exercise and sleep and all the rest of it. And one of the best things you can do for your mental health is go take an hour-long walk, etc. Anyways, those are wonderful suggestions. Thank you both so much for the conversation today. This was really fun and interesting.
Thank you. This was awesome.
Yeah, thanks for having us.